we meet again in the Australian-Indonesian glaucoma lecture series. I'm sorry that Professor Morgan actually still can't join our meeting, so I'll be trying as moderator for a while. As usual, that the session will be first case presentation by Dr. Brandon, and then the next will be Professor Ike will present about the uveitis glaucoma. So I will now give the time for Dr. Brandon to present his presentation. Please, Dr. Brandon.
All right, thank you. I'm just going to share my screen first. All right, so good evening, everyone. My name is Brandon. I'm one of the eye registrars working with Prof. Morgan actually now at Royal Perth. Thanks for having me and giving me the opportunity to present this quick case. Hopefully it's a bit interesting. So I've entitled my presentation Hidden in Plain Sight, and we'll see why later. So the case is Mrs. LP, who is a 78-year-old female who's known, who was referred to the glaucoma clinic as a glaucoma suspect. She has a family history of glaucoma with a brother, and she's currently on brinzolamide twice a day in the right eye with a pre-treatment IOP of 21. She has a significant past ocular history with previous macular off retinal detachment repair and silicone oil back in 2016. And following that, she had a cataract surgery and a removal of the oil in 2017. And she has a mild epiretinal membrane in the right eye as well. So on examination, right eye visual acuity 612 and left eye 609. And on Goldman applanation tonometry, her pressures were 14 in both eyes. So these are her visual fields. So as you can see on the right eye, there is a superior nasal step defect, which respects the horizontal midline. And on the left eye, there's maybe some superior patchy mild losses there. And then on the OCT of the retinal nerve fiber layer, you can see that there's thinning more so on the right eye with inferior and superior RNFL thinning. The left eye has a little bit of inferior thinning as well. So on examination, anterior segment findings include corneal verticillata, secondary to amiodarone. Anterior chamber was deep and quiet. In the lens, she was pseudophakic on the right eye, and she had nucleus sclerotic cataract 2+ on the left with some pseudoexfoliative material. So there's just a few photos to show. So I'm not sure if it's coming up on your screen, but there's corneal verticillata there and there. And this is just a close-up picture of the anterior lens capsule showing the pseudo-exfoliative material on the left eye. So when I looked at the discs, I was expecting to see a cup nerve and thinning consistent with the retinal nerve fiber layer OCT as well as the visual fields. But very interestingly, the discs were actually nothing like what I was expecting. So you can see the right eye, it's almost as if there's definitely no significant cupping. And in fact, you can see it's very small cup and almost a very shallow looking disc as well, with no excavation. You can also see these little yellow whitish spots on the disc. And the left eye, it's a bit of a poorer image because of the cataract, but the cup to disc ratio was probably around 0.4 to 0.5. So this is very interesting, and we looking at the OCT, it really shows you why the nerve fiber layer was thin in the visual field defects. So you can see these ovoid sort of masses in the optic disc, consistent with very large optic disc drusen. And this is just another sort of scan through the disc, better showing the large ovoid masses there. And just for comparison, line through the left disc that shows that there's no drusen there. They're very different appearances of the discs. And then lastly, the autofluorescence demonstrates the optic nerve, optic disc drusen very nicely here in the right eye and nothing in the left. So I just had a couple of learning points for myself from this case. So I was basically, when Prof. Morgan showed me this case, I was convinced that it was glaucoma, because he showed me the visual fields first, and also the OCT of the nerve fiber layer. So I think it's very important to keep in mind that that retinal nerve fiber layer thinning, even with corresponding visual field defects, it's not always due to glaucoma. There are many other causes of those. And it's very important to look carefully at the disc for these clues in terms of whether this is true glaucomatous damage or whether there's something else going on. Thank you for your time.
Thank you, Dr. Brandon, for the nice presentation. Maybe
No
we'll have the discussion after Prof. Ike's presentation.
Oh, yes.
So we will have a presentation for Professor Ike first. Please, Professor Ike, you may start your presentation.
Thank you, Dr. Firna. Good evening, all doctors, and it's nice to see you again after a Jogja meeting. And then tonight is my turn to talk, and I think I have to share my screen. Can you see my screen clearly?
Yes, Professor Ike.
Yeah. Okay, I begin ya. Oh, nggak berjalan. Yeah, okay, I'll take, yeah, sorry for the technique. So uveitis glaucoma. Uveitis is a group of inflammatory condition of the oval tract, and then it can lead to permanent blindness as a secondary glaucoma as one of the main cause. And it is called uveitic glaucoma. Uveitic glaucoma is diagnosed when the IUP is more than 21 millimeter mercury with glaucomatous optic nerve damage correspond to glaucomatous visual field damage defect. And uveitis itself is an ocular disorder that is associated with multiple infectious and non-infectious causes. There is no sex or race or age predilection, and uveitis glaucoma is more common in chronic uveitis compared to the acute uveitis. There is no differences in incidence between the anterior and posterior form, but more studies establish the anterior uveitis are the main cause. And also an open angle mechanism are the most common causes of elevated IUP. In Indonesia itself, there is a prospective study done by Dr. Ladis demonstrate that the most known etiology are infectious, and furthermore, the majority of patients consulted when the uveitis has entered indolent state, and they have already poor visual acuity with many complications. The pathogenesis of the uveitis itself, there is incompletely understood. There is imbalance between aqueous production and resistance to aqueous outflow between from the inflammations. During the acute inflammation, as a result, local vasodilation and increased capillary permeability of ciliary body, leading to the blood-aqueous barrier breakdown and plasma exudations. And there is also migration of inflammation cell to the aqueous. And then there are many inflammation cells like leukocyte, macrophage, lymphocyte, protein, and fibrin. All the inflammation cell will block the trabecular meswork. As a result, there will be high IUP with an open angle. And okay, during the episode of the acute, sorry, I think I have to go back again. Okay, during the episode of the intraocular inflammation, the IUP sometimes reduced because the aqueous humor hyposecretion from ciliary body inflammations. And there is also the increase of via sclera. But over time, multiple mechanisms can increase the resistance of the aqueous outflow during the episode of uveitis, thereby leading to the high IUP. But in chronic cases, there is usually scarring and obliteration of trabecular meswork or Schlemm canal and overgrowth of fibrovascular membrane in the angle could lead to the increased IUP, as you see here in the picture. And also, when you do the gonioscopy, you can see the inflammation participate in trabecular meswork. And another pathogenesis might be happen when you use prolonged steroid treatment can result in high IUP as well. So the secondary angle closer glaucoma, it's common in uveitis. You can see the angle closer with the purpley block.
The slide didn't Prof. The slide didn't. The slide is still in the pathogenesis of uveitic glaucoma, but the slide is not moving.
It's not moving, yeah.
Yeah. Yeah, this is okay, Prof. This is the secondary angle closer in uveitis.
Ini ditutup aja. Bentar, ya. Oke. Ini udah benar ya. It's alright ya. So, secondary angle closer glaucoma is common in uveitis, and then it can be angle closer with papillary block occur when the anterior chamber inflammation production is formed in 60 degree of posterior synechiae. It will block the flow of the aqueous from the posterior chamber into the anterior chamber as a result of iris bombae. Like on this picture here, there is a formation of peripheral anterior synechiae which pull the iris forward and then will close the anterior chamber. As the picture here, you can see the iris bombae shown in this picture. There is another feature, it's like angle closer with non-papillary block as a result of inflammation and edema of ciliary body, which ciliary body will rotate forward and closing the angle. Okay. So diagnosis of the glaucoma should be anticipated in every form of the uveitis, and then every eye doctor should be examined, include the IUP measurement, gonioscopy, perimetry, and optic nerve evaluations. The patient will feel a blurred vision, photophobia, halo, redness, ocular pain, and some patient will feel nausea related to the high IUP. According to study in Cipto Mangunkusumo, the location of the inflammation due to the uveitis, mostly in posterior uveitis, as you see here in the picture, and also panuveitis, and another one, you can see we have a very severe anterior uveitis. And also we have a few intermediate uveitis can cause the secondary glaucoma with the uveitis. So optic nerve damage should be detected by fundoscopy examination, and also you can use OCT, and then by seeing the retinal nerve fiber layer thinning, especially in the inferior quadrant. Angle evaluation is very important. Then you have to use using the gonioscopy to assess peripheral anterior cine here. If the cornea cannot be seen, anterior segment OCT is a useful tool for the diagnostic. There is a certain type of uveitis are close associated with secondary glaucoma, as you've seen here in the slide here. So there is a couple type of uveitis that are closely related to the secondary glaucoma, but I would like to discuss a few of these uveitis, such as fast heterochromic uveitis, Posner-Schlossman syndrome, and also the most common in Indonesia, the infectious one is pulmonary TB, tuberculosis. So I start with the Fuchs heterochromic iridocyclitis described by Fuchs in 1906 as a triad of mild anterior uveitis, heterochromia, and posterior subcapsular cataract. As you see here, we have very wide cataract with the anterior mild uveitis. Is quite different. It's not posterior subcapsular cataract. The disease itself is quite rare actually, but we can find a bit quite a lot in Indonesia. It is idiopathic, chronic, and unilateral, but in certain cases, it's present bilateral. The incidence of glaucoma in this uveitis varies between 13 to 59%, with higher rate seen in long-term follow-up. Predilection of the age is between 20s, 40s year in men and women is equal. The etiology is still unknown, but it is believed to be related to toxoplasmosis, cytomegalovirus, and rubella. As you see here in the retina picture, there is a cicatrization and oscillation due to the rubella in the retina. So I will send to Dr. Ladis. I have this picture from her, which is quite interesting that I can see that there is a rubella here in the retina. So if you find this sign, so you have to think there is a full heterochromic iridocyclitis. And then there is another one that you have to see in the right side here. There is a low-grade iridocyclitis without posterior cine here. And then if you take a look very closely, there is a low-grade diffuse inflammation of anterior chamber reaction. And then if you see in the endothelium of the cornea very carefully, there is a small stellate keratic precipitate around this around here. So you have to be as carefully to see there is a small sign in the endothelium of the cornea. So there is another feature we see in the, this is a patient from the Cipto Hospital, right? And then there is a nodule on the iris with the white cataract. So there is also the full heterochromic iridocyclitis. And then the other picture, which is, this is my patients, yeah. Since the heterochromic sign is quite difficult in Asian people, since we have a very brown pigmentation, so we have the diffuse depigmentation iris instead. So full heterochromic iridocyclitis glaucoma is a major threat to vision. Although initially well controlled, it may become chronic and difficult to treat. Increased IOP will persist even though uveitis have subsided and does not respond to steroid. So it gets worse as the uveitis progresses. Controlling inflammation has a little or no effect on IOP. Initially, glaucoma aqueous suppressant medication may be effective in controlling glaucoma. However, this kind of disease is relatively resistant to medication. It's like my patient, that one I have seen this morning, is the IOP is still high, even though I've already give steroid and also give the glaucoma medication, the IUP is still high. So I'm thinking about I have to do the surgery to these patients. So I continue with the tubercular uveitis. The uveitis associated with presence of a real ocular infection with Mycobacterium tuberculosis when a positive IGRA test in the absence of sign of active TB in lung or other part of the body, or it is only an immune reaction or a combination of both. The studies show that a low-grade intraocular inflammation due to the infection of with TB is possible, even in patients showing no other systemic sign of clinical TB. Some classifications have proposed several ocular uveitic presentation have attribute to the ocular TB, such as anterior uveitis with the iris nodule, serpiginous like tubercular choroiditis, choroidal granuloma, occlusive retinal vasculitis, and also multifocal choroiditis. This can find in in immune compromised person or in the active systemic TB such as tubular TB. And this picture show occlusive retinal vasculitis, and another sign that will be serpiginous like tubercular choroiditis. And the below picture here, you can see there is a tuberculoma. So if you find this sign in this retina, together with the high IUP, just refer them to the infection immunology eye specialist, and then we have to do collaboration and then treat them. And also we have to refer to the internist for treat the TB. I think it's very important to do the comprehensive for these patients. Okay, so I have this picture from Dr. Ladis as well. So it's very nice picture of this. So I continue for the Posner-Schlossman syndrome, as also known as glaucomatous crisis, occur mostly in the age of 2060s. The pathogenesis remain unknown, possibly associated with immunogenetic factor involving HLA-BW54, gastrointestinal disease, various allergy conditions such as eczema, urticaria, contact dermatitis, asthma, retinitis, food allergy. So PSS has been considered as a benign disease, as we all know. It's very benign with high IUP, and then also the anterior chamber usually wide open in the absence of ciliary on conjunctival injection. Only a small trace flare are fine and without posterior synesthesia. And you can see in the slide here, there is a mild idiopathic anterior chamber inflammation and mild epithelial cornea edema, and a very small discrete round, if you see here from the picture, and then white round keratic precipitate on the endothelium of the cornea. This is a very pathognomonic of this sign of PSS. And then you have to take a look of the pupil, which is dilated pupil, and then sluggish and respond to the light due to the high IUP. This is very important sign of the PSS. And then also, although the inflammation reaction is mild, the IUP elevation is usually severe, reaching to 40 to 70 millimeter mercury during the acute episode. Following control the inflammation with steroid and anti-glaucoma treatment, IUP usually normalize within days, only 3 days, and then the IUP go down very fast. And then we can stop the medication, and then that's it. And then the patient will go home, and then they forget their disease. But the recurrence might happen, and the inflammation can attack again. Then IUP increase may persist. So don't forget to ask the patient to come back, and then should do the follow-up for their disease, but sometimes they forget, and then they just glaucomatous damage might occur in about 10 to 55% of cases. This is why I would like to give you an example of case of a recurrent symptom with Posner-Grossman syndrome from the 44-old woman on her right eye with visual acuity is almost normal, is 0.9 in both eye, and then started in the year 2016, she experienced with severe ocular pain on her right eye, and her IUP were increased to 37 millimeter mercury, and which resolved after steroid and glaucoma treatment. And then it's going down after 37, and then only 4 days, and then the IUP is become 13, and then going to 10. And she disappeared after that. And we did blood test, was normal. Also, we also did ANA test, normal. Torch was no reactive. And then she feel fine, and then come back again 4 years later, and she have a similar symptom and resolve after 3 days treatment. After that, she did follow up in our hospital for another eye problem with no PSS. But in last August, just last month, in year 2023, she complained of very severe eye pain. When I examined her, there is a wide mild epithelial edema of the cornea with a few keratic precipitate, as you see here, very pathognomonic for PSS, mid dilatation of the pupil, self-flare was seen, and then the IUP of her right eye is 52 millimeter mercury, and normal eye in her left eye. The symptom was relieved after steroid and eye drop and the oral glaucoma and eye drop glaucoma treatment in 4 days. And up until today, she has no glaucoma treatment. I'm sorry, I didn't do any aqueous tap, and I haven't do any surgery, a glaucoma surgery. So because the patient has to do another urgent surgery. So I cannot do anything to these patients. And I also want to show you the result of her photo fundus and visual field in year 2016. We see that her Kaptis ratio was 0.7. We can see here the retina rim in superior side was thinning compared to the inferior side, and then which correspond to the inferior paracentral defect in her visual field. And this is her photo fundus and visual field in 2023. When compared to 2016, there was a small change in appearance of visual field. If you can see here, there is a bigger blind spot compared to 2016. And then when the IUP normalized, there is in photo fundus, there is look bigger in Kaptis ratio, and then when I took her OCT, revealed that a very thin retina nerve fiber layer on her right eye compared to her left eye. So I would like you to comment in regard of this case later on. So overall, the management of uveitic glaucoma, we have to control the ocular inflammations by giving the steroid treatment, topical, local, and systemic. The earlier control the inflammation, and then the better the prognosis, but we have to be aware of the increased IUP as a side effect of prolonged steroid treatment. As alternative, so we can give many kind of immunosuppressive medication or weaker steroid type. And Also, we can give a cycloplegic drop to reduce pain and prevent posterior synechial formation if it needed. So a lot of tool available to determine the etiology of the uveitis, and in order to treat the causative of this uveitis. For example, if the uveitis, the etiology of the uveitis from viral, so we have to give the patient the antiviral treatment. Or if the etiology of this uveitis due to the tuberculosis, we also have to give the patients the TB treatment. So we have we have to do close collaboration with the infectious immunology eye specialist, also with the infectious disease specialist. I think we have to do the comprehensive treatment for these patients. Anti-glaucoma medication is very important to control the IUP, and in the first line treatment, usually beta blocker or carbonic inhibitor, or we can give both by using fixed combination if it needed, or adrenergic alpha agonist. Systemic carbonic anhydrase inhibitor may be considered if the IUP is too high or topical medication is failed. About topical prostaglandin analog should be used as a last line of treatment due to potential effect of exacerbation ocular inflammation or inducing cystoid macular edema. There is some doctor doesn't want to give a prostaglandin analog since there is found that maybe there is side effect of cystoid macular edema or exacerbation of the ocular inflammation. But there is multiple study found there is no different rate of the inflammation recurrences. So it depends on the doctor itself. It can be a gift to the question of uveitis. I think it depends on the doctor who want to give the topical prostaglandins. But mioticum, you cannot give the mioticum to this patient because it can give the synechial formation, and the patient can feel pain and also can have exacerbation of the inflammation. So surgical treatment can be considered or indicated when the increased IUP persists despite maximal medical treatment. But surgery should be performed in the quiet eye for at least treatment, or maybe you can do if it is necessary. But 1 week before surgery, you have to give the patients topical or oral steroid. And during surgery, don't forget to give the injection subconjunctival steroid. And of course, after surgery, steroid treatment, topical and systemic should be given, and then tapering off according to the inflammation reaction. There are several surgery options are available for this kind of patient. And for example, iridectomy in uveitis glaucoma, there is one study done by Beth et al. Comparing this study, comparing the laser iridotomy and iridectomy surgery. The aim of this study is to identify risk factor for failure of both laser and surgery PI in patients with uveitis and to determine survival duration. And the subject is they using with wide variety and etiology of uveitis. Okay, and then the indication of why they do the iridectomy is an iris bombae, seclusion pupillae, and then primary angle closure, but no patient has had pre-existing glaucomatous optic neuropathy. And the result of this study from the Kaplan-Meier analysis revealed that median survival time was laser PI only 70 days. Meanwhile, for surgery, for survival time is 11 years. So surgical PI is superior when compared to laser PI. which could control well the IUP in uveitic glaucoma in certain case. When they calculate the risk factor using multivariate analysis, it revealed that younger patients and also with using laser, peripheral iridotomy, iris bombe are the risk factor of failure. So the study just recommend that iridectomy surgical is work well for a blockage pupil in certain cases. Trabeculectomy could be performed in certain cases, closed and open angle mechanism, and with effectivity of 81% in 1 year follow-up or 73% in 2 years of follow-up. Of course, this is uveitic eyes, the risk of bleb failure is higher to the chance of fibrosis formation on the bleb. So when you do the trabeculectomy, we have to use antifibrotic agents such as 5-FU and MC to increase bleb survival. And in retrospective study, and the retro study done by Kanaya reported that the surgical success depends on the post-operative exacerbation uveitis inflammation. Of course, because there is a lot of inflammations, and then the bleb will be failure of that. And then we also know that the GDD, glaucoma drainage device in uveitic glaucoma has a higher chance of long-term IUP reduction compared to trabeculectomy. We also know the GDD, there's various form of GDD. And then we also know as well, the GDD can transport all the material of inflammation from AC to the bleb, and then resulting fibrosis and bleb failure as well. Therefore, patient undergoing GDD implant require intensive topical and systemic steroid treatment post-operatively to avoid a tube blockage by fibrin and also bleb failure. So we have to follow up patient carefully for this patient. So this one, and also there is one study comparing the outcome among trabeculectomy, Ahmed implant, and Barford in variety etiology of uveitis, as you see here in the complicated table here. And then the tablets in this table show that Barfeld implant has was performed the most in this uveitis glaucoma with 102 eyes. When compared to the other, Ahmed implant was 22 eyes and trabeculectomy was 17 eyes. The purpose usually to compare the clinical outcome of the effectiveness this intervention, and the result of this study actually the outcome in 12 months post-operative, as seen in this table, revealed that Barfeld implant has the least of failure after 12-month follow-up, which also shown in this Kaplan-Meier analysis. The green line as represent Barfeld implant has probability of lowest failure, and then you see that here the green line of the Barfeld implant has probability of the least failure, and also the red line here show this one is the Ahmed implant. I think trabeculectomy in between. So it is believed that non-valve implant has the better outcome compared to other surgery in glaucoma associated with the uveitis. So I just recently, Dr. Julia just did her study on Virna implant. So this one is Virna implant. I think everybody knows Virna implant, and then our moderator is Dr. Virna right now. So, and then Dr. Virna just did variety on glaucoma and etiology, also many kind of etiology in this uveitis here. And then the result after very high IUP and then become going down, decreasing the IUP, and also the implant show it seemed to be promising. So thanks, yeah, Dr. Firna. You have a very good job for this one, help for the patient. So the prognosis and the conclusion, this is my last slide. So the glaucoma with uveitis is the prognosis varies according to the uveitis etiology and the severity of ocular inflammation and the glaucoma. With recurrent inflammation episode also, and the secondary glaucoma tend to have a poorer prognosis and is more difficult to control. So with recurrent inflammation, I think it's very have a poor prognosis. And surgical treatment, younger patients, male and non-glaucomatous uveitis and severe postoperative intraocular inflammation have a poor prognosis. I think this is the end of my talk. Thank you, Dr. Firna.
Thank you, Prof. Ika, for the very, very nice presentation and very exciting one. Thank you for the making my implant one of your topics. So now we will move to the discussion. There is one question from Dr. Karenia, Dr. Rere, Prof. She asks, good evening, Prof. Ike. Thank you so much for the wonderful presentation. I'm Rere from Universitas Indonesia. In cases of patients with unilateral elevated IOP, we should be aware that it can also be associated with intraocular inflammation. There are several differential diagnoses that should be kept in mind, such as anterior uveitis, trabeculitis, postnasal closement, or Hook heterochromic iridocyclitis. I would like to ask Prof. Ike, is there any practical ways on how to differentiate between anterior uveitis and trabeculitis, because both of them may show quite a similar clinical manifestations? Should we perform another workup to be sure of the diagnosis? Thank you, Prof.
Okay. Thank you, Dr. Rere. I think it's very good questions, and also is very difficult to answer as well. Yeah, anterior uveitis and also trabeculitis sometimes is quite difficult, yeah, to make a comparison. Yeah, usually, if my opinion, in anterior uveitis, the intraocular pressure usually is mild, is more mild compared with the tuberculitis. Tuberculitis usually has the higher intraocular pressure, but and also the anterior uveitis usually have the synechiae posterior, and trabeculitis usually doesn't have the anterior synechiae posterior. Is that what I mean? Synechiae posterior. But for the anterior uveitis, you can find sometimes the synechiae posterior. This one, the sign of the difference between the anterior anterior uveitis.
Thank you, Prof. Ike. I think also we know that trabeculitis mostly with the postnasal closement, right, Prof. Ike?
Yeah, I think tuberculitis is the other name of postnasal closement syndrome. And also, if you see quite be careful with the type or the sign of the kipis, yeah, in the endothelium of the cornea. The kipis and the tuberculitis is quite different from the anterior uveitis. The anterior uveitis can be very diffuse, not discrete, not and then it's many kipis on the endothelium. But in tuberculitis, maybe only 2 or 3 small dot of the round, yeah, keratic precipitate on the endothelium, and then the IUP is very high. I think that the much different on the with the anterior uveitis things.
Thank you, Prof. Ike. I hope it is answer your question, Dr. Rere. Now we will move with the next question from Dr. Iza Zuhrufa. Thank you for a very comprehensive lecture, Prof. Ike. My name is Ovi from Universitas Indonesia. I would like to ask, in Posner-Schlossman syndrome, when should we decide to do surgical intervention? Which one is the best surgical intervention, filtering surgery or glaucoma drainage device? Thank you, Prof. Ike. Please, Prof. Ike.
Yeah, thank you for the question. I think like the same, yeah, I already present the example from the Posner-Schlossman syndrome with the uveitis. As you know that only 50% with the syndrome as I think, yeah, I think Posner-Schlossman syndrome usually related to the glaucoma usually, yeah, have a very high IUP. And then if you find, for example, this one, the one that I show you, the recurrences is coming in 4 years, and then after 5 years, the recurrency that happening. But I have reported in my journal, I think I've already put in my journal, I have 5 patients. I do the trabeculectomy with releasable suture because I did the trabeculectomy in those patients due to the recurrences 3 times in a year. So I think we cannot do anything else since the glaucoma is progressing because of the IUP is too high, and then it will damage the optic nerve. So we have to prevent further damage for the optic nerve. So if trabeculectomy fail, we can do another surgery such as maybe a glaucoma drainage device. You can do by Virna implant or Ahmed implant or Barfeld implant. So I have one study that I read there from a journal. There is a comparison between Ahmed or Barfeld in the PSS patients with the glaucoma, and Barfeld has the better result comparing the Ahmed. I think it's depend on how damage the optic nerve and how often the patient get the recurrences of the disease.
Thank you, Prof. Ike. Is it,
I think what your experience, Dr. Virna?
Oh, about Posner-Schlossman, Prof. Yeah.
Yeah.
We know that Posner-Schlossman sometimes it is not that as simple as that, right, Prof? Sometimes it is not just like a recurrent uveitis and without like any damage to the optic nerve. Sometimes if I find the patient with Posner-Schlossman and then the patient already has a visual field defect or maybe optic nerve damage, then I will try to do the maybe trabeculectomy with the mitomycin C first, Prof. So because one thing that I have read, there is a study in Singapore that they actually found that Posner-Schlossman sometimes it moves to primary open angle glaucoma. So it's more or less like a patient with Posner-Schlossman. In the end, they will have like a condition like a primary open angle glaucoma. So usually I will just do the trabeculectomy with antifibrotic agent, and then we will see. Usually it worked quite well, Prof, in my patient, but I didn't do many cases of Posner-Schlossman with trabeculectomy, maybe only 1 or 2 cases.
Yeah.
Okay. Yes. And there's also another question from Dr. Amani, Prof. Good evening, Prof. Ike. Thank you for the inspiring lecture. I'm Amani from Universitas Indonesia. I want to ask a question. How do we consider corticosteroid use in uveitic glaucoma, particularly in post-operative eyes? Which goal should be our main priority, to control the inflammation or to maintain the IOP within the target? Thank you, Prof. How do we consider corticosteroid use in uveitic glaucoma? Particularly in
I want to,
operative
I
eyes.
don't understand the question. Post-operative eye. Yeah. Maybe the question is related
Which
to
goal should be?
yeah,
Maybe it is
before
related with the steroid.
yeah,
Yes,
before in the list in my lecture, I told that I said that before the surgery, we usually it is said that we have 1 week before surgery we have to give the patient oral or eye drop the steroid treatment to prevent the exacerbation of the uveitis, or maybe if there is a uveitis, if it is, I think it's better we have to wait in the uveitis should be a very quiet uveitis. I think, yeah, I think it would be better if there is a very quiet uveitis and then we do the surgery on that kind of patients. But after that, so we have to continue the steroid treatment, I think. Yeah, we have to continue, and then we have to see the inflammations, the exacerbation of the uveitis itself. I think it's very important. And the main goal, of course, the main goal, of course, we have to reduce the intraocular pressure, and then the wound healing process. That our main goal. We have to keep the bleb form well, diffuse, and then a little bit vascularizations. I think that our main goal to do the surgery. We do the trabeculectomy, either do the implant. I think that's our main goal. After if we do the glaucoma surgery. I hope you yeah.
Amani, Prof.
Amani.
Dr.
I hope
Amani,
you are satisfied with my answer. So
maybe Dr. Amani want to say
8
something.
o'clock already.
Okay. Oh yeah. Okay. That's 8 o'clock. Okay. Thank you, Prof. Ike. I think it's already 8 o'clock. Actually, I want to ask Dr. Brandon, Prof. Maybe the last question.
Oh
Is he
yeah,
still
Dr. Brandon. Yeah.
Is he still here? Or
Yeah.
yeah. In your cases, actually, you present with the other eye, the one with like a picture of exfoliative materials, right?
Yes.
Yes. Is it considered that this patient actually has a pseudo-exfoliative glaucoma, the one that you, or maybe pseudo-exfoliation syndrome? Because as we could see that one of the sign of pseudo-exfoliative glaucoma is actually there is like materials on the anterior capsule. What do you think?
Yeah, that's right. Yeah, so it's possible, but I think her intraocular pressure in that left eye was never sort of raised, but she's still being watched, obviously, because of the retinal nerve fiber layer thinning on the left side. So, but it's been stable over the years, so we're just watching her at this point in time.
Okay. Is it also there? Do you find also a drusen in the left eye?
No, there was no drusen in the left eye, so it was very unilateral, very asymmetric.
Because
a bit,
yes,
yeah.
because as we could see that actually in the left eye, in the OCT examination that you show, actually there is also a thinning in the inferior side. Yeah.
Yes, that's correct. Yeah.
Because you mentioned that in the right eye, it's actually it is related with the drusen. As we could see, the thinning is actually related with the drusen. But if you said that in the left eye there is no drusen, so the thinning should be related with something. So
yeah, so I think we're still there's no real visual field defect yet, but yeah, that's why Prof is still monitoring her and making sure that she doesn't progress in that eye.
Okay. So maybe because sometimes, pseudoexfoliation syndrome, maybe
Yes.
for prior they become the glaucoma, when we,
Yeah, maybe.
yeah, the syndrome. So,
Yes, that's correct. Yeah.
and then sometimes also they could fluctuate the IOP when whether the exfoliative material block the trabeculum or not, or something like that. Yeah, so
Yes.
maybe is it worthwhile to have like a diurnal variation IOP measurement or 24-hour IOP measurement, maybe something like that?
Yeah, I can ask Prof when I see him next.
Okay,
See,
thank you.
yeah, I'll let him know. Yeah.
Okay, send my regard to him.
Yes.
Okay,
No worries.
everyone.
Yeah.
So we will end our session. It's already 8 o'clock now, and maybe it is 9 o'clock in Perth time. So we will have our photograph session. Please, Dr. Miki, if you don't mind, and everyone, if you don't mind to turn on your camera, so we could have a photograph together. Please, Dr. Miki, you could maybe.
Okay, thank you, Dr. Firna. I would like to ask everyone to turn on your camera as we will begin our photo session shortly. Okay, we will begin in 10 seconds. So everyone, please turn on your camera. Okay, we will start conducting our photo session. Everyone, give us your best smile. 1, 2, 3. Next page. 1, 2, 3. Third page. 1, 2, 3. Fourth page. 1, 2, 3. Fifth page. 1, 2, 3. Sixth page. 1, 2, 3. And the last one. 1, 2, 3. Okay, it's all done. I'll give it back to you, Dr. Firna. Thank you.
Thank you so much, Dr. Miki. So we will end our session. Thank you so much for your for your attendance in our Australian and glaucoma lectures, Indonesian glaucoma lecture series. We will have our meeting in the next month. Hopefully, you will also join this session. Thank you so much. Have a nice day. No. Have a nice rest for the day. Thank you. Assalamualaikum warahmatullahi wabarakatuh. Good evening, everyone.
Thank you.
Thank you. Makasih ya, Prof.
Dr. Firna.
Lengkap
Thank you
banget,
so
Prof.
much. Kenapa?
Lengkap banget, Prof.
Alhamdulillah. Thank you, Firna.
Sama-sama, Prof. Sehat-sehat
Thank
semua ya,
you.
Prof.
Ya,
Thank you,
saya
everyone.
izin.